Delhi Ophthalmology Society for giving me this opportunity to talk about optic neuritis in multiple sclerosis. We all know multiple sclerosis is an immune-mediated disease of the central nervous system, which is characterized by inflammatory attacks against the myelin, which leads to progressive axonal degeneration and eventually leads to a permanent disability. Hence, the importance of diagnosing this disease early and treating the same. Optic neuritis is the demyelinating inflammation of the optic nerve, and which is basically an extension of the brain. The connection between the optic neuritis and MS is that 20% of patients with MS present as optic neuritis, and the lifetime prevalence of MS optic neuritis is around 50 to 66%, and half of the patients with typical optic neuritis will develop multiple sclerosis within 15 years, according to the ONTT. So, optic neuritis first attack can be described as clinically isolated syndrome, which is basically defined as the initial presentation of any demyelinating inflammatory disorder which has not demonstrated dissemination in time required for the diagnosis of multiple sclerosis. So the first attack may remain a clinically isolated syndrome, or what we call idiopathic optic neuritis, or recur and relapsing optic neuritis may either be multiple sclerosis or because of NMO spectrum disorder or crayon or rayon. Now, it is after the treatment of the acute attack of optic neuritis or the clinically isolated syndrome, it's very important that we pick up the predictors of multiple sclerosis. And MRI predicts strongly the risk of developing multiple sclerosis. The characteristics of demyelinating lesions would include 3 millimeter ovoid lesions that are mostly located in the periventricular areas in the white matter and radiate towards the ventricular spaces. The risk of developing MS at 15 years in a patient with first episode of optic neuritis is 25% if at presentation the MRI is normal, and it becomes 72% if one or more lesions are present. The other risk factors for developing MS include family history of MS, younger age of onset, winter onset, neurological findings associated with the optic neuritis. And the risk of MS was 3 times higher in women according to ONTT. Presence of CSF-OCP also is a predictor of MS. Recurrent optic neuritis again indicates MS. It's very important to pick up the old attacks of optic neuritis and silent attacks of optic neuritis. Hence, the indicators of functional and structural loss of axons in the optic nerve have an important role. The functional health of the optic nerve is easily picked up by the VEP. If the waveforms show increased latency and reduced amplitudes, it indicates demyelination, and it's fairly sensitive and specific for detecting optic neuritis even in silent cases. The structural damage to the optic nerve can be picked up by the OCT, which shows RNFL thinning or GCC thinning, which is an indirect indication of axonal degeneration and atrophy. McDonald's criteria are the most utilized diagnostic criteria to assess the MS conversion risk in patients with single demyelinating episode by providing MRI evidence for dissemination in space and time. ONTT was the very important study done in 1992, which still guides our treatment of acute optic neuritis, and it showed fellow eye involvement in 14 to 15% of cases and showed disc swelling in 25 to 40% of patients. Visual recovery is faster in the patients treated with IVMP, and the study stated that at the end of 6 months, the patients treated with placebo, oral steroids, and IVMP, all three regained the same amount of vision. Let's look at some cases of optic neuritis and multiple sclerosis. This 30-year-old female presented with a painful decrease in vision in the left eye, but on examination, she had bilateral disc edema. The visual field showed involvement of both the eyes, but the left eye definitely denser defects. The MRI showed a T2 signal in both the optic nerves with a thickening of the left optic nerve, and the brain MRI showed typical periventricular plaques called Dawson's fingers. So this acute attack was treated with IV methylprednisolone followed by oral steroids. Patient was sent for the neurology consult to rule out MS, and at the end of 1 month, patient had regained the visual acuity back to 6/6, visual fields had cleared, disc edema had disappeared. So this is what a typical optic neuritis in multiple sclerosis behaves like. This is another case of a 29-year-old female who presented to us with painful decrease in vision in the left eye, and there's a very subtle edema on the left side. Again, there are periventricular plaques in the brain MRI, and there's a cord involvement also. Treated with IVMP, sent for neurology consult, and started on disease-modifying treatment. After the IVMP treatment, visual fields has cleared. 1 year later, despite being on the DMT, the patient developed a decrease in vision in the right eye, that is the other eye. And though the vision was 6/6, the field defect can be seen here as a quadrantinopic defect. An important insight in this slide is that left eye, which was previously affected, the visual field is normal, vision is 6/6, but the OCT tells us another story. The OCT is able to pick up the left eye RNFL thinning on the this graph, and in the GCC also you can see it as red and yellow areas. So though the eye with the acute attack, the scan is normal here. So an old attack, as we saw previously, the structural health of silent and old attacks can be picked up by these investigations. This patient's MRI brain orbit spine was repeated because the patient was on disease-modifying treatment. There was a decrease in number and size of plaques, but despite the treatment, the patient had a recurrence in the other optic nerve. So let's look at in brief at the treatment. Acute treatment is IV and oral steroids as recommended by ONTT. If it doesn't improve, can try Plex and IVIG. Long-term management depends on the MRI findings basically. If there are demyelinating lesions of patient has recurrent attacks, associated neurological symptoms, consider DMT. If the MRI brain is normal, then follow up closely. This is a very crowded slide telling us about the options of disease-modifying treatment for long-term management. Basically, for very long, interferons have been used to prevent recurrences of MS. Of late, we have got fingolimod and teriflunomide oral drugs, which makes it easier for the patient. And if the patient cannot afford or tolerate these, immunosuppression also can be tried. Thank you.
Thank you, Dr. Shikhar. That was an amazing presentation and very well summarized. And